YNA is a podcast that focuses on mental health and other aspects relating to what goes on inside of a person's head. We are by no means professionals in this field and only aim to make these conversations about mental health easier for the listener. Nothing we say or talk about is professional advice unless explicitly mentioned. If you seek professional advice or experience symptoms of an actual mental disorder, please contact a professional or visit your closest center for behavioral health. You are not alone.
What's up, guys? Thanks for listening to today's episode. If you're looking for more of our content and merch information, be sure to check us out at ynamentalhealth.org. Keep an eye out for our skits and upcoming episode information. Feel free to reach out to us on IG. Our DMs are always open. And please remember, you're not alone.
Hello. Welcome back to You Are Not Alone. I am here with Dr. Nelson, and this episode is on OCD. Dr. Nelson, do you want to give a little bit about who you are, what you do, and a little bit about your credentials?
Sure. I am a licensed clinical professional counselor in Illinois and Wisconsin, and I have a doctorate in counselor education and supervision. I've been a counselor educator as well as educating other professionals about mental health conditions and best practices.
So I've done a little bit of research on what OCD or obsessive compulsive disorder is, and I personally have learned a lot, but I feel like you could really shed a lot of light on what this disorder is about, what we can expect from it, what people who struggle with it and how they can manage with it, and kind of get an understanding of the treatment. So our first question is, can you explain what OCD is?
Sure. There's two main classifications of OCD, or obsessive compulsive disorder. One is OCD, the other one is OCPD. OCPD is obsessive compulsive personality disorder. The second one, the personality disorder, is usually lifelong, and it's kind of built into people, so it's very hard to treat. It's characterized by a lack of awareness, so someone with OCPD doesn't really, they're not conscious of how dysfunctional they are, and it tends to adversely affect relationships. An example of that would be the TV show Monk. That's a great example of someone with OCPD. Obsessive compulsive disorder is more common and is more related to anxiety. And so the obsessive part is thinking. People have thoughts that they ruminate on and they can't get rid of. And so that's the obsessive part. The compulsive part is then acting on those thoughts, and that's a compulsive behavior. So there's the thinking part and there's the behavior part. Put them together, they tend to cause people distress.
Wow, so it seems like it's plays a lot of hand in hand with what anxiety does, and as you said, like with ruminating, the thoughts just don't stop, and it doesn't seem like you can get a full control of it. What are the simple symptoms of OCD?
It is characterized by anxiety. So basically, one way to look at obsessive compulsive disorder is someone has anxiety and they try to come up with a way to manage the anxiety, and it tends to reinforce itself. So think of let's say someone that has an obsessive compulsive disorder around cleanliness. So they're afraid of getting sick or getting germs or something like that. They can't get that thought out of their head. So then the behavior part is obsessive hand washing, where it damages their skin, or they might avoid people, or they might maintain their environment or their house in a sterile kind of condition that interferes with relationships and other things like that.
So I actually have a story that kind of jumps off of what you're talking about, a lot about like skin picking. A person mentioned, I used to spend hours organizing my toys. I'd pick at my skin until it hurt too much or I was bleeding. I was almost certainly constantly touching my hair, and I would obsessively seek out certain textures and avoid others. I'd be in the greatest agony if I had to touch or hold a bad texture. I would be almost consistently counting in my head. I thought all of this was normal, then one of my parents became ill and my symptoms got worse. So as you were saying, a lot of picking at skin, biting of teeth, is this it doesn't seem like it's a normal thing to do, but how do people manage something that's consistently hurting your own physical body?
Well, in our world in mental health, it's an issue when it has negative consequences in life. So if someone is just moderately skin picking and it doesn't cause any medical condition or harm them, then that's something that we wouldn't diagnose. But it's when something becomes excessive to where it's interfering with their ability to function in life, that's when we kind of usually end up getting involved. But it could be something that's physical, like skin picking. It could be cutting. Could also be a host of other things like sexual compulsions or, like I said, cleanliness, hand washing, all those kinds of things. But it gets so pervasive that it interferes with someone's ability to function in life and messes up their relationships, might hurt them vocationally, those kinds of things. And it usually starts off smaller. So let me give you a kind of this is a fictitious example, but let's say that I have a irrational fear that there's of lions, and I think there's a lion outside. My brain's telling me there's a lion. There's a lion, you're in danger. If I have OCD, I know it's irrational, but it still causes me distress and anxiety. So then let's say I bang on my door and then I open the door and there's no lion there. So now I get hooked by that. So in other words, my brain is tricking me to that pounding on the door makes a lion not be there. And then I find that I have to pound on the door. I can't go outside because I think there's a lion there. And it just goes on and on and on. So it's really a misguided way to deal with anxiety in a way that kind of tricks our brain, but it becomes limiting and it interferes with our ability to function over time because we get trapped in it.
That sounds so difficult too, because it seems like we've said this a lot on the podcast that your brain is your best friend, but can also be your worst enemy at the same time. And I feel like that is something that people struggle with is like, what do I trust? How do I trust my own thoughts? How do I get this thought to kind of these ruminating emotions and effects to kind of go away and not allow myself to stay compulsive to these kinds of things? You mentioned a lot about maintaining relationships and friendships. How does OCD affect your ability to maintain relationships and friendships?
OCD starts to interfere because I might, in essence, when I'm anxious, I'm avoiding whatever is the source of my anxiety. So I'm trying to find a workaround in my mind, and that is where I get caught up or tricked into the dysfunctional behaviors, and then that has a trickle down effect at typically like work, school, home, where other people notice my behaviors are weird. And again, with OCD as opposed to OCPD, the person knows their thoughts are irrational. It's not that they're oblivious to that. They know it's irrational, but it still plagues them, and they feel compelled to act on those thoughts to alleviate anxiety or distress. So it's similar in a way to addiction, where I have a trigger event and then I want to self-medicate my emotions. And the person with OCD does that through behaviors, which can include addictive behaviors as well. But it's a separate diagnosis from like substance use disorders.
With triggers, it seems like with a lot of disorders that these triggers play such a important part to causing what your disorder becomes. How do you manage these triggers? It feels like there's no way to really stop them. It seems like you can calm them down more than anything. But is there any way to like kind of get your hand around it and grasp it instead of allowing it to free flow through your mind?
That's a really good question. So the overarching answer is we have to face whatever it is that we're afraid of. So one of the best practices for OCD is called exposure therapy. And basically what I do is I have to face whatever it is I'm afraid of and not withdraw or avoid it until my anxiety decreases by about 50%. So let me give you an example. I had a client once that was robbed at gunpoint at work, and they were duct taped in chairs, and they all thought they were going to die. And luckily, they weren't killed, and they all were safe in the end. But then that person couldn't go back to work. And so a way to do exposure therapy that we did with this particular client is we had her rank order a number of things that caused her anxiety on a 0 to 100 scale. And we started with something like driving by the location of work and going home. And then she'd drive through the parking lot and go home. And then she'd drive and park in the parking lot for a minute or two, then go home. And then she'd drive, get out, get back in her car. And then she would drive, get out, go up to the door, touch the door, get back in her car and go home. And then she'd walk in, then she'd walk out, then she'd stay longer. And so what exposure therapy is very effective, but it's also very unpleasant because I have to sit in the feeling that I'm trying to avoid, sometimes for quite a while, until my anxiety decreases, and that breaks me out of the anxiety kind of trap that is prevalent in obsessive compulsive disorder. So that's the overarching thing, is I have to face the things I'm afraid of. More practically and probably in smaller pieces are things like thought stopping techniques. That can be anything from snapping a rubber band on your wrist. But one of the cognitive ways that's really works for a lot of people is to count backwards from a number that's picked at random, like 125 by threes. Most people have to really think to do that, so it distracts their mind from obsessing about the anxiety producing thing. So best practices for OCD is probably going to be exposure therapy with response prevention is technically what it's called. However, there's some evidence coming out of the Netherlands that EMDR, eye movement desensitization reprocessing, can be very effective with OCD because EMDR was created primarily to treat post-traumatic stress disorder, panic disorder, those kinds of things. It's super effective. Because OCD is an anxiety-based disorder, EMDR can be very helpful and effective with treating it too. And there's a couple EMDR techniques that can be super effective. One is called EMDR 2.0 CID, and basically you do bilaterals, and then at the same time you tax your working memory. That would be something like counting backwards. We have some information on our website about that technique, but it's like a cognitive way to thought stop, but on steroids. It's really amazing and powerful how it works. And it's based on EMDR, so that's another technique that can be used to kind of shut the brain down.
I know that one of the techniques of EMDR is the tapping technique, and also counting backwards is something that really helps distract the mind in EMDR, and it's really important to keep using just to keep your mind kind of active. It seems like distractions truly help you figure out, like, to set your mind away from the difficulties of whatever you're going through. And if you can take that time to give your mind kind of like a break, it allows you to kind of realize how much distractions can help. I think the big question is, how do I know it's OCD and not anxiety? Because they play such a big part together, but they seem to be also separated in very large forms.
That's another good question. So a lot of times mental health conditions can mimic each other, and that's also true of substance use disorders, can mimic mental health conditions. So we as clinicians have to tease out using diagnostic criteria, but basically there's a couple different types of anxiety. I categorize it as generalized anxiety, which is I find myself anxious, but I'm not really sure what I'm anxious about. I don't have something specific, not like a phobia where I'm scared of snakes or spiders or something. The other is panic disorder, and that's just more extreme. That's where someone would have an adrenaline rush and they would have like palpitations or feel like they're going to throw up or get dizzy or their knees would wobble. It's basically an adrenaline rush. The kicker is, though, that my thinking process can increase my anxiety. So let's say that I'm worried about getting fired and I start noticing weird things at the office. So then I start to ruminate on that. I get more and more anxious. And sometimes that can turn into a self-fulfilling prophetic thing where I start acting weird because I'm so anxious, and then that draws more attention. And it can turn into kind of an anxiety tornado. That can cause panic. Similarly, if someone has a panic disorder, once they've had a panic attack, then they become anxious about having another one. So they kind of go together. But with the OCD, the anxiety is kind of the fuel that stimulates the obsessive thoughts and the behaviors. In other words, my brain is trying to get me out of a uncomfortable situation and tricking me into ways that are non-productive to do that, rather than facing my fear and dealing with it adaptively.
With OCD and anxiety, there come different ways of diagnosing each one, whether it becomes a level of spectrum to what kind of level is my OCD or anxiety. How is OCD diagnosed?
Well, the big thing is it has to cause, in our clinical jargon, significant impairment or distress. In other words, it has to cause trouble in life. So most people might have times where they're a little OCD and can even joke about it. But OCD that is diagnosable is causing someone distress in their life. It's interfering with relationships, with work, with functioning. And that's when it becomes something that we would end up clinically diagnosing. Generally speaking, though, you have to have the obsessive thoughts, you have to have the compulsive behaviors, and it has to cause clinically significant impairment or distress. So that's an overarching way that we use to diagnose it. But there are assessment tools that we use. There's probably even stuff people could do online to kind of check and see how significant their symptoms are. But to be properly diagnosed, someone needs to go to a qualified mental health professional to officially be diagnosed after an assessment process.
So I have another story for you. When I was a kid, I had a strong urge to have everything balance out, specifically with touch. If I touched something with my right hand, I had to perform this exact same touch with my left hand. Same amount of time, same pressure, same surface. I felt really uncomfortable, and if I couldn't achieve that, I always had intrusive thoughts. As early as 6, I'd have these thoughts of me hurting somebody, including my family, and internally scolding myself for thinking them. Now, on the outskirts of the whole thing, a family looking in, how does the support of a family and friends help manage somebody who's going through a situation like that with OCD? How do I look at it from an outer point and help this person? Because I'm trying to understand how to not make their OCD worse, but to actually help them get to the level of being balanced out, being understanding of what they're dealing with.
That's a great question. It's a little complicated. So social support is really important for everybody. Everybody needs people that they can count on, and that's one of the things that we look for as mental health professionals to assess problems. Is if someone is overly isolating. It's fine to have some solitude or some just to get away from myself for a little while, but too much of that is a symptom of a problem for most diagnoses. So that's one thing we look at. The other thing is that family members and loved ones may not understand what's going on, so they probably want to be seek some support themselves to get educated. But one of the best things to do is ask the person, how can I help or what can I do? If they don't know, that's another issue. So again, going back to the OCD, there's the obsessive thoughts and the compulsive behaviors, and that's treated by having someone sit in the anxiety, not avoiding it. Family members sometimes will inadvertently enable, like they're trying to help, but they can kind of throw water on a grease fire where it spreads the fire. So if someone's OCD is acting up, family members might enable them by allowing them to excessively hand wash or something and participate in that process, which is actually going to reinforce the problem. And so that's where it's counterintuitive treatment, like the exposure therapy is counterintuitive. It's very unpleasant, but it's very effective. And it's really what's oftentimes necessary to get someone through the OCD. So if loved ones inadvertently enable that person by, let's say, calling them into work and making accommodations that they wouldn't make for somebody else, that's going to probably entrench the disorder deeper in their loved one. And so that's where it's prudent to get a mental health professional involved to help both the person that is identified with the problem, but also the family to help support in a way that helps that person get better and not reinforce the problematic behavior.
And there's a lot of people out there who really have the difficulty of just being like, I need help. I need to figure out when I need to get help. And it seems like the question that a lot of people can't seem to understand is, when do I need to seek help? So if I had OCD, or if I'm having these compulsive thoughts, doesn't mean I have OCD, but how do I know when to seek help for it?
If it bothers you, seek help, because it's better to do it quick rather than later. The longer I wait, more often than not, what happens is the disorder gets more entrenched and becomes a bigger problem in my life, and it's harder to treat. Just like a medical condition, like if my appendix is acting up and I ignore it, and let's say I take painkillers and everything, I could be doing harm to myself instead of going in and getting checked out. And so if something is bothering you and you're concerned or you're worried about it or you're even wondering about it, find out. There's relief that comes with knowledge. Knowledge is power. So just go get checked out. Some people have the misrepresented idea that they have to really, really be severe, have a mental health condition or whatever to get checked out. We do all kinds of stuff. We do coaching. We help relationships improve. We help people figure out what's going on. And sometimes people freak out. So here's another example. I had a client that was scared of driving across bridges. and she had to go across the bridge to go to work. And when she would approach the bridge, she would think terrible thoughts of drowning her children in the bathtub. And of course, that caused her a lot of disturbance. And I kind of normalized it and said, your brain's just trying to trick you. You're scared of the bridge, and your brain's like, think of something horrible so that I don't think about what I'm afraid of. And then she's like, oh, that's what it is. And then she's just like, oh, that's not a big deal. And I'm like, no, it really isn't. So sometimes people catastrophize stuff that is really not a big deal, much like people do with medication or like physical health. Like I have a headache and I think I have a brain tumor. Well, I might have a brain tumor, but I get checked out. Chances are I just need some Excedrin or something. And the same thing in mental health. Go get checked out, ask some questions, find out, and then there's some just the reassurance can really bring calm and peace back into my life rather than me wondering.
Now we're on the side of treatment and figuring out what is the best treatment for OCD. As you said, there's many different theories and many different ways to get help through therapy and counseling. Is medication a way? Can that help your OCD? Is there pills that focus on helping you with that?
Yeah, I'm not an MD, but sure, medication can be helpful in our world. Medication is something that we challenge clients to pursue when the normal coping techniques and things that are best practice for different disorders are not enough in and of themselves. But in most cases, like for OCD treatment, the exposure therapy or the EMDR that's focused on the OCD will get someone to where their symptoms are so reduced that they don't need medication. If that's not the case, though, then we can get medication on board to help someone work through whatever it is. I have a saying that I'd rather work smarter rather than harder. And some people are really against medication and when it's necessary. And I'm a fan of what works. So if my coping skills and strategies and therapy isn't working in and of itself, your therapist will probably refer you for a medication assessment by a psychiatrist or maybe your primary care physician.
So with the treatment, you can find daily management with your disorders and figure out how to live a normal life, because with people with mental health disorders, it seems like they feel like they can't live this normal life, but you can with the proper treatment, whether it's counseling, whether it's medication. If I am someone with OCD though, and I want to let other people know, like my friends, if I'm ever feeling some sort of way, how do I educate them to make sure that they can understand and I don't feel the stigma of, oh my God, like I feel scared to tell these people, like I'm worried that they're gonna look at me some sort of way or think I'm some crazy lunatic. How do I help them?
Probably the first thing is to get educated ourselves. So find out what's going on. And most people struggle with something at one point or another in life. So I'm going a little bit on a rabbit trail here, but for example, suicidal ideation. That's where I'm thinking that I might be better off not being here. That's common in people when life is just really kind of in a bad spot, especially when several areas of life we're struggling in at the same time. Suicidal ideation in and of itself is not a huge deal. It's pretty common. And we take it seriously, but we assess the other factors. So suicidal ideation by itself is not super alarming. Suicidal intent, that's when I intend to not be here. That's a whole nother story because we have to assure for everybody's safety. But most people at one time or another have some suicidal ideation. And that is not abnormal. It doesn't mean somebody's mentally ill. It's just a kind of a thought that I think when life is really, really hard and I'm kind of worn out. And that usually clears up by itself. And if it doesn't, then we need to get some therapy. And if that's not enough, then we seek medical attention to assistance with medication. Same thing with OCD. Most people at one point or another have some OCD traits. We might like things a certain way, but that doesn't mean we're mental or deranged or something like that. It's when it gets out of control and life becomes kind of unmanageable, then we need to make sure we seek professional help. But I would like people to do that when they first notice something that bothers them. Go get checked out. It's not that big a deal. And chances are you'll get some reassurance, you'll get some skills, you'll get some techniques that'll work, and then you won't even have to worry about it moving forward.
Do you have any tips for someone who just wants to get their first foot in the door of counseling. They just want to get the help, but there's just this barrier or this wall that just every time they come close to it, it scares them away from it. Because it feels like that's what it's become nowadays. Do you have any tips just to get them through the door?
Sure. One thing is to, again, educate yourself. So, for example, let's say that you have some kind of health insurance. You can go on the website of your health insurance provider and look for therapists in your area. You can also Google and see who's highly rated. Psychology Today and some other places have provider lists that have profiles of different providers. Find someone that seems to resonate or click with you. And then think of it like almost like a date. You're just going to go in and get to know someone and for an hour and see how you feel about them and if that's a good fit for you. And if not, you could try another one, but just kind of one step at a time, take the plunge. So if you break things down into smaller steps, like look online, see who's in network, do a little Google search, look at some reviews, pick someone you're interested in, give them a call. Just do one step at a time. Go and see. That's all you're doing. You're not like marrying that therapist. It's not a lifelong commitment. You're just going to go check it out and see if that person makes sense to you and it seems like a good fit and it clicks for you. Just take the plunge. Just go and see. That's one of the best things to do. And that's also one of the best things to do for like OCD is go and see, like open the door without banging on it and see if there's a lion out there. But I have to face my fear to do that. And really that's what therapy and recovery is all about, is dealing with the things that we were avoiding so that things go back to normal. And that's what we want for everybody that we work for or work with.
And everyone out there is no lion behind that door. You can do this. We believe in you. Just take the first step. And like Dr. Nelson said, like you can truly figure out what's going on, educate yourself, educate others. And that's the most important part of this whole thing. And so we just wanted to thank you again for coming on the podcast, kind of explaining everything. If you haven't already, Dr. Nelson has been with us before. He has an episode on bipolar, manic depression, and he gives an awesome understanding of what that is. You can check that out on our podcast list. And to everyone who listened, we just want to remind you, please remember you are not alone, and we will catch you on the next episode. Thanks again, Dr. Nelson.
You're welcome. Thank you.